All right, so I welcome everybody. This is going to be the guest speakers from Ascension Oncology, Susie and Michelle. They're going to talk to us about their job, career, answer questions for you guys. So I'll let them introduce themselves and we can get started.
Hi, my name is Susie. I'm a lead radiation therapist here at Ascension in Racine.
And I'm Michelle Strong. I'm a dosimetrist here.
All right, and we'll get started here. So just to kind of go over some basics, the definition is radiation oncology is a branch of medicine concerned with the study of cancer and radiation. Radiation damages cells by breaking of the DNA strands. Cancer is a disease at the cellular level where growth becomes abnormal. You can see in the pictures below, just kind of see how the normal looks and how it kind of gets more and more. You can see, and on the right side, that's cancer there. It's not pretty. So here I just have a graph here of the most common types of cancer in the US. You can see male and female. Breast and prostate are still the highest. You can kind of see the areas. It's just kind of interesting to see, you know, where all the most common cancers are. Sorry, we're trying to get this thing to hide. There we go. So there's a lot of cancer risk factors: tobacco, diet, sunlight, alcohol, ionizing radiation, chemicals, and family history. There also are a lot of cancer detections you can do. That's why we, really try to do community outreach to teach patients, their annual checkups, the screening they can do, to catch these things early. There's regular screening for cervical cancer, breast cancer, colorectal cancer, and prostate. Even when you go to the dentist, you should know they're doing a screening in your mouth just to make sure everything looks good. So, you don't think about these things until you're at it. And it's just like, oh, I got to go get my checkups. And they'll do evaluation of symptoms. And these early detections really do save lives. It's silly, but it's true. So there's a couple of different methods for cancer treatment. We have surgery. It can be prior or post to radiation treatment. Some surgery is before, and then we do radiation. I like to use radiation as a vacuum. So they do the surgery, and then the radiation's there just to suck up any extra cells there to make sure that we got everything. Otherwise, sometimes a tumor may be too large, and so we'll do radiation to shrink that tumor, and so then it is operable. So there's a lot of different options. The next option for cancer patients is chemotherapy. So chemotherapy is a drug that's administered orally, injection, or topically. It kills the cancer cells and healthy cells. So, you do get a lot of side effects with this. And this travels to the entire body. And I have this here. How is that different from radiation? Because radiation only affects the cells we're treating. So if we're treating breast, you're not going to get these side effects in the prostate. Well, I guess breast and prostate wouldn't be in the same body. But if we're treating breast, you wouldn't have these side effects in your head. So that's the difference between chemotherapy and radiation. And the chemo works on the DNA and cell cycle. Radiation therapy. Radiation kills cancer cells. It requires a high energy and high doses. Approximately 75% of cancer patients will need radiation therapy in their lifetime. It's pretty crazy. In this image below, this is an example of a radiation machine. So this is the table the patient lies on, and this moves around them. And so that's kind of what it looks like when you're getting radiation. So here we have a radiation team. This is actually our oncologist here, Dr. Rosenberg. So we have a pretty big team here. So we have a radiation oncologist, a radiation therapist. This is me right here. We have a radiation physicist, a medical dosimetrist. And then we also have a huge ancillary team that we can connect patients with. So we have a nurse, social worker, dietitian, chaplain, genetic counselors, financial advocates, navigators. So we kind of do this holistic approach. So if we have a patient that's losing weight and can't maintain their weight, we'll set them up with a dietitian to give them shakes to help them maintain their weight. If someone's having difficulties with trying to afford it, we'll set them up with our financial advocates. If they can't keep their appointments straight, then we'll hook them up with a navigator so we can really make sure all their needs are met. So the roles of a radiation oncologist, I mean, he's the top dog of this place. He really is overseeing everything. He conducts the tests and examinations to confirm the diagnosis. He is the one who creates the treatment plans and make sure that we're giving the accurate dose and everything that we can destroy the tumor, but make sure that the healthy cells are staying healthy. He executes the radiation treatments like the stereotactic. He monitors the patient's skin for side effects, make sure they're handling the treatment okay. And he's consistently monitoring the patient's progress. He sees them weekly to make sure they're doing okay and make sure there's nothing they need. And then he will provide them with pharmaceutical drugs if they need it, if they're really having a difficult time throughout the treatment. So he's just an all around there for all the patients. So this is kind of what I was talking about side effect management. This picture here, I mean, this very well could be a side effect from the radiation, the reddening, if they were treated for head and neck here. Like I said, it's limited to the area that they're treated. Most common side effects are skin reddening, fatigue, and hair loss in the area treated. There are medications and interventions to help. That's why the weekly checkup with the nurse and doctor. The radiation therapists also monitor the patients daily because they see them daily and will refer them to the doctor if the side effects are getting too bad. After the patients finish radiation, they're not totally done with us. They do have to come in for follow-up visits. Some may have to come in sooner if the side effects are worse, but the doctor will decide when the appointment should be scheduled. They check on the status of the disease and side effects. Once the radiation's done, that doesn't mean that the radiation is done working in the body. The radiation can affect patients up to 2-3 weeks after the treatment's done because it's still affecting the cells. So we have to keep checking up on them to make sure that they're doing okay. So the roles of radiation therapists, they review the treatment plans created by the oncologists and physicists. They explain the treatment plans and process to patients. We are a huge emotional support to the patients during, before, and after treatment. We get to know them. We see them every day, Monday through Friday, from 1 to 44 treatments. We make sure we protect them from unnecessary exposure to radiation. We maintain and operate the Linac machines that treat the patients, and we observe them for adverse reactions to treatment. We record and track all the treatments for the radiation. So this is a CT simulation. All these little modes are stuff we use to make sure the patient stays in the same position for every treatment. And next here, I just have a little video of an example of what a simulation would be like.
Welcome to Tampa General Hospital's Cancer Center. Today we will show you what to expect on your first day of CT simulation, also known as your treatment planning session. The goal is to make you as comfortable as possible for your future treatments. Treatment planning sessions vary depending on the area of focus. Planning sessions generally take 15 minutes from start to finish. First, we will start with making and molding the immobilization devices, either a mask or what we call a vac bag. You will use these molds for each visit. Then we'll map out the area of treatment, which means marking the molds as well as the patient. We then proceed with the CT scan. Once that scan is completed, we'll apply permanent tattoos to the area of treatment and photograph the marked areas. For head, neck, and brain cancers, we use 2 types of mask, long and short. To mold the mask, we will place it in water to make the material stretchy and pliable. Once we have fitted the mask, we will put marks and small BBs on it for positioning later in the treatment room. We use the mask to prevent movement and ensure accurate targeting of the tumor during treatment. Vac bags look like clear plastic bean bags and are used for your chest and pelvis, as well as arms and legs. It is formed around the patient to keep them in the same position for a precise treatment daily. Sometimes doctors request that patients lie on their stomach for their treatment. In those cases, you will be placed on a prone belly board or a prone breast board. After your scan, we will create a treatment plan for your daily radiation. Once the plan is created, the dosimetrist will conduct a quality assurance or test run on your treatment plan. Once the plan has passed testing and health insurance has been approved, we will call you to schedule your first treatment. We hope this video will help you understand what to expect on your treatment planning simulation.
So this is not our cancer site, but that's exactly what a simulation contains of. Every patient, they may have the same cancer site, but none of the setups are the same. Some patients can't raise up their arm. Some patients can't lie on their back. So each patient gets a specific setup that makes them tolerable to hold still for 15 minutes. We do make those masks. They're very neat. What they do is they make sure the patients have to hold still throughout the treatment. And then this sim here, it's not a diagnostic scan, but what it does is it creates a scan for our dosimetrist to start planning. We can see the depth. We can make sure that we're avoiding all the healthy tissue and just treating the cancerous tissue. For everyone to get radiation, they need to have this planning session done.
Welcome to Tampa.
So for the actual treatment delivery, after they get that simulation, Mish will do her planning, and then the patient comes in for their actual treatment. In order to be able to treat, it has to be accurate. We do not want to treat any healthy cells. We only want to kill the cancer. So we have to make sure that the patient is set up in the same position to make sure it's accurate and precise. The patient, like I said, must be consistently positioned in a line. That's the whole purpose of the CT stimulation. And we treat to the isocenter. The isocenter is the point in space through which the central ray of radiation beam passes. I expect you all to memorize that. So the other part of treatment delivery is it's the same dose daily, the most common dose. This will mean nothing to you, but it doesn't change. Like one day we give 180, one day we give 200. You give the same dose every day and it accumulates on top of each other. And so that's why when they finish with radiation, it's not done. It continues, the cells continue to kill that cancer 2 or 3 weeks after the radiation is done. Patients can come for anywhere from once to twice a day, for 1 day to 44 treatments. So we really get to know these patients. I mean, every day they come in, it's almost like a therapy session. We really get to know about their lives, their family, and be that emotional support for them. And every day we do image guidance on all these patients. So we take an X-ray or a scan to make sure they're within 1 millimeter for their treatment. So this is kind of what a treatment console looks like. We always make sure we can see and hear the patient. We have to keep accurate records of the treatment. We cannot be in the room during the treatment because the radiation is going. But as soon as the beam turns off, there's no more radiation in the room. So it's completely safe. So for schooling for radiation therapists, so you have to go, it's highly recommended to get a bachelor's degree, but in some hospitals and places you can go with an associate's degree. You have to go with like science, physics, biology, and get into a program. So there's only, from when I went in school in 2012, the only UW La Crosse was the only school in Wisconsin for this radiation therapy program. So there's other like Illinois, Minnesota, they have some, and maybe since I was in school, there's another program that opened. But yeah, so you have to get accepted, and then you have to meet the minimum standards of education. And then once you get accepted, there is a 12-month internship you have to do for your final year. So that's when you really get into the treating and the compassion and being there for those patients. After you pass your 12-month internship, you have to get registered to do your exam. Depending on where you want to work, they may require a different state license for each state you want to go to. So you may have to do different exams for different states. And then every few years, you have to update your credentials by doing CEs. You have to do some tests. You can do some readings to keep up on those, but you are updating your your certification every year.
And next are the roles of a medical dosimetrist, which is me. When a radiation oncologist prescribes a radiation to a tumor, a medical dosimetrist, which is me, creates the plan to deliver the prescribed radiation dose. It's my job to ensure that the radiation treatment promotes the most lethal dose to the patient's tumor with the fewest side effects to their healthy organs. It's my job to make sure that I don't damage the patients in ways that are irreversible, such as paralyzing them, causing blindness, etc. So during the planning sessions, the physician locates the actual tumor volumes. I then go in and draw all of the areas at risk, all of the other organs that are in the way. Pretty much every single place that you would deliver radiation to, other than say an arm or a leg, has organs and tissues that we want to avoid because we don't want to damage the normal tissue. We use lots of imaging. We use PET scans and MRIs to help us see these different organs and tissues, because every scan has a different sensitivity to different areas. We use something a lot called intensity modulated radiation therapy, where literally there are movable segmented shielding devices, or we call them MLCs, that produce a custom dose distribution. We can literally, with the use of all of these individual lead leaves here, we can customize the dose to any different patient. You could probably take, you could take 5,000 patients with head and neck cancers, and no two would ever be the same, which is part of the challenge and excitement of being a medical dosimetrist. Planning has evolved so much. I personally have been in radiation for over 30 years. And even though we use the same linear accelerator that we used since it was invented in the 1950s, it has so many bells and whistles on it. We've been able to very much increase the dose that we give to patients, thereby really increasing the ability to cure many of the cancers out there. We used to have to irradiate a lot of normal tissues in order to get to the tumor volume, and now we can literally conform it right around the tumor itself. To be the schooling involved for medical dosimetrists is very it's highly Susie, what's the word I'm looking for? It's highly competitive.
Yes.
To be a medical dosimetrist, you have to complete a 4-year college degree, preferably in the physical sciences. Upon graduation, you must be accepted and graduate from a JRCERT accredited medical dosimetry program. Those initials, JRCERT, are extremely important. If you go to a program that is not JRCERT accredited, you will not be allowed to sit for your boards. There are apparently, I just spoke with the only program in Wisconsin, which is also at UW-La Crosse. And the head of the medical dosimetry program let me know that there are 16 programs now in the United States that are JRCERT approved or accredited. These programs are highly competitive and last anywhere from 12 to 24 months. We'll go back to the rest of our presentation. The reasons for radiation. Number one would be to cure someone, which is the vast majority of our cases. We generally go to very high doses. They usually will have to come in many more times than for someone who we are just trying to palliate. Palliation is another reason for radiation. It is basically to comfort. So reasons why we would want to palliate someone would be bone metastasis that is causing them pain, or potentially risking a fracture of their bone. There can be lung tumors that are already stage 4 because they've already gone to the bone, but they're causing coughs, shortness of breath, hemoptysis, which is coughing up blood, It can cause other things where you literally cannot, your upper body cannot drain the fluids. There can be brain metastasis that's causing brain swelling and or neurological symptoms, seizures, blindness. So we'll go in and usually do a much less, maybe half of the dose that we would go to if we're going for a cure, and maybe half of the time they would have to come in. Because once again, we're just trying to alleviate their symptoms.
And these are like life or death situations.
Some of them can be life or death. Yeah, we have a few oncologic emergencies that are urgent emergencies. Somebody could have a tumor that's around their spinal canal that's causing them to be paralyzed. We also do, so these are all types of external beam that we've kind of talked about with this big machine, this linear accelerator. Then we also do something called brachytherapy. And it's the treatment of cancer by inserting literally radioactive seeds and or capsules directly into the tissue of the patient. There are some of these where we put them inside of the patient's body, let's say for a female GYN cancer, and we let them sit in there for a period of time, literally minutes, while they're in a sheet, and then we take it out. And we maybe do this 1 to 5 times on different days. Then there are also cases where, like a prostate seed implant, where we literally put anywhere from 80 to 120 individual seeds, radioactive seeds, in their prostate, and they can remain in there indefinitely. The reasons for all of these have to do with radiation physics, and if this is something that excites you, please feel free to reach out to us. There's something called Gamma Knife, which in this dome, there are, I don't recall exactly, but almost 200 sources of radiation. It's basically surgery without a scalpel. It's usually just only used for brain tumors, best for very small lesions. This field is always evolving. Even though this presentation is relatively recent, there are evolutions already that are occurring. That's something that's also very exciting about the field. It's nothing that you just do and 2 months later you're doing the same exact thing. It's constantly evolving. The technology is constantly growing and changing. There's something called total body irradiation, which is we literally treat the patient's entire body prior to a bone marrow transplant. We're trying to eradicate any of the tumor cells that could be potentially left after chemotherapy. Sorry about that. And then we have a treatment video.
Yeah, so in that previous slide, you'll see these shields, and the only thing that they're blocking for this is the patient's lungs. Otherwise, the entire body receives the radiation. It's very hard on the patient. A lot of them get really sick after. So this is a treatment video. I'll kind of talk about this is a gantry, and this is what a patient would receive during treatment. This is kind of an example of a patient's first treatment and how you set the patient up. And this is all a job of a radiation therapist. So we'll play this here.
This radiation therapy treatment machine is called a linear accelerator. It uses electricity to create powerful X-rays. During treatment, you'll lie down on the treatment couch. The couch can be moved in several directions to help get you into the right location. We will use a system of lights, lasers, and computer readouts to help with that, so the room is usually semi-dark. The machine can also move around you, but it will not touch you. The X-rays come out of the machine here. The beam of X-rays will be shaped precisely to suit your needs. The direction and shaping of the X-ray beams is different for every patient. They are planned out by your radiation oncology team using a 3D computer model of you made out of your planning CT scan. This scan and other information is used by your doctor to determine where they want the radiation to go. They also highlight normal organs that need to be avoided. In this case, the doctor has marked an area that is close to the kidneys and spinal cord. Several beams have been used to give a high dose of X-rays to the target, shown in red, while other parts of the body get a lower dose or are avoided. Your plan has been created with the same sort of precision, which is why the treating radiation therapists will take great care in positioning you the same way you were when you had your planning CT scan. Your radiation therapists will use lights, lasers, and reference marks to help position you. Sometimes they'll ask you to assist with small movements, but mostly they will ask you to keep still as they adjust your position. Once the team have positioned you and gone through their checklist, they will leave the room. You will hear a beeping sound as they go.
And you can see there that the door is super thick. That's for
While the
making
staff
sure
are
we
outside
block
the
out
room,
all the,
they
it's
can
very
see
thick
and
to
hear
make
you
sure
on
that none of the
closed-circuit
radiation
TV.
leaves the room.
A microphone also lets them speak to you during treatment. Before treatment starts, the staff may use these robotic arms to take images. These images allow the team to see bones inside your body and make sure that they are positioned in the same way they were when you had your planning CT. If necessary, fine adjustments can be made before the treatment starts. During treatment, you will not feel or see the radiation, but you will hear the machine buzzing. Each X-ray beam delivers a specific amount of dose each day. They generally last a few seconds each, but some can go for a minute or more. Your radiation therapy team will tell you how many beams your doctor has prescribed and give you an estimate of how long it will take each day. If you have any questions at any point, the team will be happy to assist you.
So the radiation treatments last about 15 minutes. There are some treatments that we do a very high dose that lasts for about an hour. And so the patients have to hold still for about an hour. And if you have any more questions about schooling and stuff, I didn't do the greatest job at explaining that, but you can just Google it. I would search UW La Crosse and it goes over exactly what you need. Once you go in, you have to have these classes before you can even apply. And really, I would really stress about getting a bachelor's degree because, the more degrees you have, like that's, better and better, especially if you want to move on to dosimetry because you need really a master's for that, so it doesn't hurt to really further your education with that.
The other thing Susie and I have talked about numerous times in today's world is the importance of shadowing.
Yes.
Shadow, shadow, shadow. Whatever you think that you want to do, just shadow. Reach out to your neighbors, reach out to a hospital, because until you actually live it and breathe it every day, you really don't know if it's something that you would want to do.
Yeah. And you can shadow us. We love to have people shadow us. So
I really wanted to find a dosimetry planning video, but unfortunately, the only ones I could find were about 10 minutes long and they were so in depth. We just didn't think that it was appropriate for this, but I'd be more than happy to share information if anybody's interested.
Yeah, we're always welcome to give out more information. We have our emails here. So if you're interested in it or just want to even see what it's about, get more information, please reach out to us. We love sharing our knowledge. And that's about it. And then we're open to any questions anyone has.
I guess I'll go for a question. So, hi, my name is Kush. I'm a senior at Case. So the question I have was, I remember learning like last year about like metastasis, and how that if that occurs, then surgery is an option. Why is that so?
So it depends. So when a tumor spreads to other organs, sometimes surgery is an option because it may not be like a brain tumor. It can't be near vital organs that if they touch it, it would kill you. So a lot of times when it spreads, it's near a spinal cord or it's in the brain that they don't want to operate because, maybe the patient's already in bad shape and then they can't recover from the anesthesia or they can't recover from the surgery, So a lot of times in those cases, we just do the radiation because it's less invasive and then they don't need any scars. They don't have to recover from anesthesia. They just lay on the table. So they can get surgery. It just has to be in a place that isn't touching vital organs. Like it can't be next to a spinal cord that they could paralyze the patient, or if it's maybe like a lung, they could maybe get in there. It just depends on like the size, the placement, you know, all of that information.
And every patient, that's what's so unique about this field, is every single patient comes with a different tumor, different everything. You know, another reason sometimes with metastasis, if you are already a stage 4, perhaps they will deem, like Susie was saying, that you're not a candidate for a surgical procedure for whatever reasons, be they physical or whatnot.
Yeah. And it, like I said, it doesn't always have to do with the tumor placement. They may look at you and say, I don't know if you're going to be able to recover from this surgery cut. Like, or, you know, you have an infection and I don't think you're going to recover from this anesthesia. You know, there's so many things you have to look at a person's being when you're doing surgery, or even radiation for that matter. You know, you have to look at the quality of life. And, you know, for metastasis, another option is just quality care, putting them on hospice, you know, making sure that their meds are straightened out and they're comfortable. That is another option for patients that have cancer. We always like to have patients get a consult for hospice and just give them the option, because some patients may not want to lay on a hard table for 15 minutes or get surgery or have their body, you know, full of toxins of chemotherapy. So that is another option they can do.
And there are many patients who can have stage 4 metastasis and live with it for many, many, many years, you know, many years, 5, 10 years. So it can be a very viable option if you're a young person.
Yeah, absolutely. Any other questions you guys have? I know we had one of our people that were telling us about this were asking us, you know, how our job changed during COVID. And I'll just ask ourselves a question. So during COVID, you know, all of our patients were allowed to have visitors with us to get radiation, and they are not allowed to have visitors. You know, now we're opening it up a little, but before that, they weren't allowed to have visitors, you know, so they were coming in for these super vulnerable appointments. You know, they have to take their shirt off. They don't know us. They really get to know us throughout the treatments, but, you know, they're very vulnerable in this. And, you know, during COVID, they were alone. We had to wear masks, so they really never fully got to see us. You know, we had to stay 6 feet apart, so we can't hug our patients, you know, or emotional support for them, but we can't hug them. You know, it's very strange. And then half of our staff was working remote, like Mish was working remote. So we didn't have everyone there. So, you know, COVID really changed the whole perspective on, like, you know, having staff there, having family there for emotional support. It just, you know, it kind of like rocked our world in radiation as far as being there for our patients.
So here I'm gonna come. It's probably not gonna be like directly to the topic or what we discussed here, but like I have a grandfather that had like a tumor or something like that on a bone, and like after when they treated him, it would like spread all over the face, and it left him like worse than he was. Like, what would you do in that situation when you would discover like a tumor in the face by the bone? Like,
I think every case is so unique that to speak, you know, on some grand scheme about one particular case would be inappropriate. You know, that would be, you'd have to discuss that with the whole, you know, your grandpa's whole team.
Yeah, because it's hard to know. Like, you could say, okay, yeah, he had a tumor on the bone, but who knows what the size of it or what the stage of it was, you know,
or
like,
the cellular histology,
the cellular growth, or how fast it's growing.
Right.
You know, like we could say like, oh, these are the options they would give, but like to look at a patient and say like, these are the options. I mean, you need a full history consult of what did your family have? How are you feeling? How is their, you know, what age are they? What is their quality of life? I mean, there's so much that goes into what what patients could have options,
Multiple studies. Yeah.
And if there's a research, that we could do a research on, Frater does a lot of research and what's the word I'm looking for?
Clinical studies.
Clinical studies, a lot of those that if there's not a lot of options, there's clinical studies to do. So, I can't really give you a full answer, but
and as I was saying too, like during the medical dosimetry part, you could take 500 patients with head and neck cancers and no two would be the same in anything.
Yeah.
So sorry, we can't help you.
I know.
Oh,
I'm
yeah.
sorry. We're good at
Yeah.
our job, but not that good.
But yeah, like right now it's not my grandfather, it was like my grandmother's like brother. So
Family.
reality, like they got like 90% of it done, like, but like what's with the other 10%? Like what kind of like how could they not like resolve the problem like 100%?
So what did he have? Like, did he have radiation?
I think he had radiation treatment on him or something like that, but like he waited like for 4 years and then it spread all over. And it was between the hospitals in Mexico and Florida and everything like that.
Okay. Yeah. So that's the thing. So, if there's a tumor that's in the lung, okay, and it's just in the lung and, it's an early stage, perfect. There we go. And even when we say the word cure, sometimes there's like, 90% chance cure. Sometimes there's like a 25% chance cure, and so when you're talking about like spreading, so that's the thing. We need to know like the cell type, because some cell types, they spread like wildfire. I mean, you could come back in a week later and it's already spread to more parts of the body. So once something has already spread, it's so hard to stop it because we can't just give someone radiation to their whole body. I mean, then we're damaging healthy cells while trying to kill the tumor. So you have to look at that, like, once it's metastasized, then you're looking at doing chemo too, and then radiation possibly, and then, they're weak and, it's just really hard to stop it at that point.
Genetics are huge too. And these, genetics, back 20, 30 years ago, we didn't really understand nearly what we understand now.
Yeah.
Even the cancers that we understand now that come from things like HPV, female cervical cancer, usually male oropharyngeal cancer, the genetics of things, you could take a bajillion breast cancers and those who have the genetic side of it don't do nearly as well.
Yeah. Well, and like on top of that, like you're saying, like, they couldn't get the rest of it. Every organ has a maximum dose they can receive before you're harming that vital organ. So they may be like, we're almost there. We got all of it, but we cannot risk, killing this heart organ that you need to live just to, finish treating this cancer. So there's just so much information that goes behind when trying to, kill these tumors.
I got a question that kind of goes along with that now. So if you say, all right, we can give this maximum dose to this organ, is there like a time frame then where you say, all right, we'll give it this much time and then we can come back to do more radiation on it?
There are equations and calculations that can be done to figure out the radiobiological effectiveness and, say 5 years after, 20 years after. There are very good limits for every single organ. And some organs you may just damage, but you can potentially live without that organ. Let's take kidneys, for example. You can live with one kidney. Your brainstem, if we go over that dose, your brainstem is what allows you to breathe and have a heartbeat. So if we go over that one particular dose, anytime in your lifetime, you will not live. If there are organs such as your kidneys, everything else that's in your body, and you come back 10 years later, yes, our physicists can sit down and do a calculation and say, okay, 10 years ago, you got 4,500 centigrade to your spinal cord, which was the maximum dose at that time. Now that 10 years has passed with this calculation, and I'm just making this out of thin air, we are going to say that you got half that dose. So we can now give you half of that again. But once again, it's very individualized. It very much has to do with how much time has passed.
Because healthy cells regrow. So we treat patients Monday through Friday. So then they have off Saturday and Sunday. And part of that is, we want to kill those cancer cells. We don't want to give too much of a break because we don't want to risk the cancer cells growing back, but we also need the healthy cells to have a break because we need them to regrow. We have this blocking, but we can't block every healthy cell. If we're going to treat this tumor, we might have to shave a little here and treat part of this lung or something. And so that's why they need these Saturday, Sundays off to not only relax and enjoy their time outside of the cancer center, but so these healthy cells can grow back and keep going during this radiation, because some people come in for 3-4 months. That's a lot of radiation.
Right. It works, like Susie said, it's on a cellular cycle. And so we keep damaging little by little the tumor cells, and along with it, some good, healthy cells. But the tumor cells eventually can't recover, but the healthy cells can because of time off, because of it. Exactly.
Regrowth. Yeah.
And somebody asked a question in the chat. What are qualities candidates need to work in this field?
Ooh, well, qualities. A radiation therapist, you see these patients every day. I mean, I've never seen a radiation therapist that's like constantly in a bad mood. You need to have this like bubbly personality so that you can be there. A lot of the patients just love like hearing about your story so they can stop thinking about their cancer for once. You need to have a lot of compassion. The main thing here is your teamwork. I mean, you have to be able to work in a team environment. We are constantly in communication, talking about plans, talking about re-simming patients, stuff like that. So you need to have good communication and teamwork skills, I think. And I think you have to have the will to keep learning. Technology is always changing. It's good if you like to work with computers because we work on computers all day long. So I think like just that technology side of wanting to, keep learning.
And for, I was a therapist for many years also before I got into medical dosimetry. You also have to have a lot of smarts. You have to understand a lot of anatomy, physiology, radiobiology, radiation physics. You may not actually use that every single day in your job, but you have to have all of that baseline knowledge. To be a medical dosimetrist, number one, as Susie was saying, it's a team, and communication skills are huge. We can't make a mistake. We're not just taking an x-ray of somebody's finger. We're delivering lethal doses of radiation. So communication is the key for medical dosimetry. I think the ability to enjoy minor details. There's no stone left unturned. My entire job is basically 75 to 95% of my day is spent in front of 2 huge monitors, creating these treatment plans, meticulously going through slice by slice. Let's just say I literally will look at slices from a CT scan, maybe 280 slices that I have to go through every single slice and draw all of the organs that are in there, their spinal cord, their kidneys, their liver, their lungs, their heart, their optic chiasm, their brainstem, their bladder, their rectum, you name it, everything that's in there. And then I painstakingly have to figure out how to get those beams, how to get that radiation to that tumor without hurting everything else that's around it. It's very high physics, radiation physics, radiation biology. And just what's cool about it though, I mean, it's high stress, but you're also very highly educated. I have the power to hurt somebody. So it's very important that I'm extremely precise. But what's cool about it in the same aspect is that it's a challenge. It's a daily challenge. No 2 cases are ever the same. No 2 patients' tumors are ever the same. No 2 patients' anatomy is ever the same. So it's a constant challenge, which I enjoy.
Yeah. Well, I always think of dosimetry as working on a very, very, very complicated puzzle all day. You can try out a bunch of different pieces, but you need the exact piece to make sure we're treating the tumor and, keeping the healthy cells alive.
And the therapists are the ones who run the show. They're the ones who are there. I'm behind a computer screen.
Yeah.
I have the stress of what I'm doing, but they have the stress of the patients there with them live.
Yeah. And you need, I mean, and this is not the best part of my job, but you have to be able to deal with grief. I mean, we do have patients that pass away, and you have to find some way to deal with that. I am not like, I had to study to be good at, radiophysics and biology. So don't be scared if you're not good at that stuff, because, you're in a specific degree, these teachers, you're in for radiation once you're in the program. So, that's what you study, and that's what all your classmates in this program are doing. So don't be turned off if you're like, oh, I'm not good at physics, I'm not good at biology. I'm not good at biology, and I'm a therapist here. I'm a lead therapist. So, it just shows you like you can learn. It's not, it's not overly terrible, but, you do have to have this side of like, you can still deal with grief, and you can still be there for your other patients. You can't get hung up on if your favorite patient dies, which they have, you just have to be able to find a way to, move on and help these other patients.
And interestingly enough, when I was in high school, my worst subject was math. And I think because I didn't find any application for it, because my whole job also too is it's all numbers. Everything is numbers. What is the dose going to the spinal cord right now? Oh, it's 4,489 centigrade.
Yeah.
Well, my limit is 4,500. So, it's all numbers also too. But if math doesn't interest you, don't fear, because I think it's more of the tenacity and the analytical thinking, and you're just not going to let anything go to rest until you have looked at it in 17 million different directions. So if that's your personality, medical dosimetry would be great for you.
We probably scared him off now.
But there's that one person in there who's going, this is for me.
Still here.
Sounds like a lot of fun.
I'm still here. You didn't scare me away.
There you go.
Yeah, you get a lot of patient contact. I mean, I went into healthcare wanting to help people. That's what a lot of people go in for. And these patients you get to see every day. I mean, you really make a connection with them. And they come out of here and they're like, I don't want to go. Like, I love seeing you guys every day. I love you. It's just, you really make a difference on these people's lives. And it's just amazing, to be able to, heal someone from cancer. I mean, it's just the most powerful thing in the world. It's just truly amazing.
And the patients are happy to be done, but literally they cry because they're going to miss the staff. They're going to miss the therapist so much because they've been there with them through thick and thin.
Yeah.
And interestingly enough, also too, there are only 4,400 medical dosimetrists, I say in the world, because they are the ones who are registered with the medical certified dosimetrist board. So there's not a lot of us around here, which is why I said if there's one who's interested in this, that's a big deal.
I have a quick question.
Yeah.
Right now in my class, we're doing like presentations, and my presentation, our group presentation is on hormone therapy. So like my question is like, at what stage would you recommend using like pills or injections or even surgery? Like how moderate or how severe does the case have to be in order to decide which one?
So this is kind of like what we were talking about earlier. It all depends on placement, size, staging, person's well-being, quality of life, stuff like that. So what happens is, and I could probably give you a name of our supervisor in upstairs to kind of, if you want more information. But basically what will happen is once a patient's diagnosed with cancer, they're going to have a consult with a radiation oncologist. They're going to have a consult with a surgeon, and then they're going to have a consult with the medical oncologist. All three doctors are in constant communication talking about, I just saw this patient. I think they should have radiation first, then surgery. Or if they're not a surgery candidate, I think they need to have chemo and radiation. So they're all three in constant communication, and then they will figure out a plan together what's going to best help this patient. So it's not any specific, I can't tell you like any, like, stage 3 size, 1 centimeter, perfect. That's the person who's going to get hormone therapy. It doesn't really work like that. Every patient, there's no like stage 1, stage 2, stage 3, this is what they're getting. There's recommendations, but every patient's different. So you just can never say like, this is what's going to happen. And some patients may refuse, Some patients may say, I don't want to come in 30 treatments. I'm not getting radiation. I'm just going to get chemo, you know, so it really depends.
It is very much a team approach.
Yeah.
And very individualized.
Yeah. Sorry that we didn't help you much on that, but there's really no good answer for that.
Are there any other questions from anybody? All right.
If you guys are interested in like what machines and stuff we have, you can email us if you want to kind of look up. There's so many different like treatment machines, and you can kind of look up like both of our jobs. And again, if you're interested in any other information, or you can just take our emails, email us if you want to shadow us. We love having people come over and visit us. So feel free to reach out to us. We're this nice all the time.
Well, thank you very much. I'm going to stop recording, and then, like I said at the beginning, I'll share out the video so other students can watch if they're interested, and hopefully get some more interested in these careers for sure.